Start the recording. So we'll begin. So as I said, we're going to talk about fluid balance and shock. So there are a lot of times when this is going to be incredibly important to you, whether you are working in the community, working in an acute care setting, working in a long-term condition setting. There's all sorts of different areas where this is going to be an incredibly important thing for you to consider. So what are we talking about when we talk about fluid balance? You've all spent some time in the skills labs and you've all spent some time out in practice now. So you are probably fully aware of these things, but so this might be a little bit of revision. So what's the function of the body fluid that is transported around our bodies? We need to transport oxygen because we need to send oxygenated blood all around our body and all around our tissues to ensure that our every organ is working to its optimum and all our tissues are well oxygenated. We need to take carbon dioxide away when the process of metabolism has been completed. We need to transfer nutrients all around the body. We need to transfer electrolytes. We need to send chemical messages from the brain and from other organs in the body around the body to send messages. So it's like a communication system. We need to transport cells around the body. We need to take waste from certain places and move them to other places, and we need to take heat from areas that are hot that need to be cooled and vice versa. So it's got enormous amounts of complex reasons why our body fluid is so important, not only to maintain but to regulate. So how much fluid do we have in our body? I'm talking about the average 70 kilogram man and the average 70 kilogram female. So obviously these numbers need to be adapted slightly depending on weight and also importantly depending on age. So 60% of a 70 kilogram male is approximately 42 litres and 50% of a average 70 kilogram woman is 35 litres. So we're looking at quite a lot of fluid. That's not just blood, that's all fluid. So we're talking about all the fluids that are travelling around the body. So the total body fluid is going to be different and changes according to, we've already said sex, so there's a different amount of fluid in a man as there is in a woman, only slightly different, but that's an important thing to consider. Age is an incredibly differentiating factor. Do you think the amount of fluid you get gets bigger or smaller as you get older? Okay, I've only had 2 answers, all 3 now. I'm going to pause. I'm just going to pause for a bit longer to see how many more answers I get. Okay, so I've had a number of answers. I've had a number of varying answers actually, which is quite interesting, isn't it? There is a variation in what you're coming back to me with. So as you get older, a small proportion of you, and this is just related to age, so it's not related to anything else, a small proportion of you are saying that you get more fluid, and a much larger proportion of you are saying you get less fluid. So the majority are correct. As you get older, the amount of body fluid you have in a healthy, normal, older person is less than a younger person. So if you were 25, a 70 kilogram woman, and between 25 and 40, the previous slide would apply to you. So 50%, 35 litres. So around 25 to 40 we consider to be not young, but a normal amount of fluid. When you pass 40 years old, that amount of fluid, if you are completely healthy and you've got no other health conditions, will go down. You will have less fluid as you get older. So those of you who said less or smaller or reduced were correct. If you said bigger, I'm wondering whether you're thinking it's related to something else. So if it's just about age, the amount of fluid you have in your cells is less. And the reason for that is the elasticity of all of your cells decreases as you get older. So when you are younger, your cells are very buoyant, for want of a better word, and they are able to regenerate very quickly. And as you get older, that goes down, so they become less elastic. So their ability to hold fluid becomes less and less. And that's every cell in the body, not just your blood or your skin. It's every cell in the body. So as you get older, the elasticity in your cells becomes less. So hopefully that answers your question. Now, the other dependent factor, we've got body type, we've got sex, we've also got health status. There are many, many long-term conditions, and there are many physiological conditions that will cause a change in the amount of fluid that you have in your body. Can anybody think of a particular condition that might affect the amount of fluid you have in your body? Some great answers are coming through then, but predominantly one of the answers that's coming through is kidney damage, kidney injuries, kidney problems. So yes, if there's anything wrong with your kidneys, which are like considered to be the tap of the body, they regulate the amount of fluid that we retain and that we excrete. So they're very much the controlling factor in our body. So yes, if there is a problem with our kidneys, that is going to make a big difference to the amount of fluid that we've got in our body. So whether it's an acute kidney injury, as somebody's mentioned, kidney failure, chronic kidney disease, any kind of kidney problem will influence the amount of fluid that we've got in our bodies. A couple of people have mentioned liver damage, and you're also absolutely correct. If we've got any damage to our liver, that can have a knock-on effect to a number of organs, and it can change the amount of fluid that we've got in our body. People have mentioned things like cellulitis and edema. That's can be a side effect or a presentation of particular diseases. and therefore will definitely change the amount of fluid that we've got in our body. Somebody's mentioned heart failure, which again is a great answer, because the heart pumps, it's the pump of the body, so it's sending the amount of fluid that we're sending around the body. And so if that is failing or has failed in any way or has any kind of disease, then that's going to have an influence on the amount of fluid that we've got in our body. So we're coming up with some really great answers. But one thing I hope you're realizing is that there are a lot of diseases that are going to make an awful lot of differences to the amount of fluid that you've got in your body. So if you think about the amount of people that you've looked after in this first year of your training, how many patients have you looked after that don't have anything wrong with them at all? I would suggest, I'm not expecting an answer to that question, everybody that you look after has got something wrong with them, otherwise they wouldn't be in your care. But in all of the things that we've just mentioned, I would suggest that many of your patients have. So the people that you're coming across day in and day out are going to have something wrong with their heart, something wrong with their kidneys, something wrong with their cardiovascular system, something wrong with their liver, something wrong. And so we are now talking about a lot of our patients will have some influencing factors on the amount of fluid that they have in their body, either causing them to retain fluid, which isn't good, or not have enough fluid, which again is not good. So having that balance is incredibly important. And so we're talking about practically everybody we look after. So the changes that can happen in the body according to, as we've talked about age, we've talked about sex, and we've talked about health status. When I talk about body type, then I'm talking about probably your BMI and your level of fitness. So somebody who has an elevated BMI, who is overweight, will have more fluid in their body than somebody who has got a low BMI and is underweight. So again, if you think about not just the age of your patient, but the weight of your patient, as well as the health status of your patient, all of these things are going to have an influence on the amount of fluid that they've got in their body. So in the average day, how much fluid is gained and lost? So on one side there, we've got approximately 1,500 mils of fluid is taken in. We've got about approximately 700 mils of food is taken in a day. And the process of oxygenation and breathing in and out causes you to gain approximately 200 mils in a day. So we've got a rough total of 2,400 mils in a day is taken in. An average, if you have on a normal day, and this is a normal temperature, comfortable temperature, you've got skin evaporation and skin perspiration. You've got expiration, so that's you breathing out. How much you lose in feces and how much you lose in urine is approximately 2,400 mils in a day. So if we wanted to keep ourselves in an appropriate level of fluid balance, we would have the same amount going in as we have coming out. There are all sorts of factors that will influence the amount that we need to take in and the amount we might lose. So we might take in a lot more fluid. We might be thirsty. It might be hot. We might have exerted ourselves. We might have done some exercise. So we might increase the amount of fluid that we take in. Because we're doing exercise and because it's hot, we might lose more in perspiration. We all equally might lose more when passing urine. So the body, when everything is well, will lose what it needs to lose and retain what it needs to retain. So if you are in balance, you will put in approximately the same amount that you put out. So being in fluid balance is about having the right amount of fluid in the right place containing the right solutes. So what I mean by that is having the right amount of fluid in the right place is really important, because if we have drunk an enormous amount of water and taken it in orally, but we have some dysfunction in our gut and therefore we can't absorb it, then that fluid is going to be in the wrong place. Equally, if we've got some blockage in the ureter or the urethra and we can't pass urine, we might have an awful lot of fluid on board, but we can't lose it. So it's about having the right amount of fluid in the right place at the right time, containing the right amount of solutes. Because if we've got a lot of fluid, drink, water in our gut, but it's diluting all of our nutrients, that might not be a good thing. Equally, if we've got a bladder full of urine, which is a waste product, and it can't go anywhere, that's when it can backtrack to the kidneys and cause problems. And we will then have toxins in our system that shouldn't be there. So it's about having the right amount of fluid in the right place at the right time, containing the right things. Are there any questions on that? No questions at all? Okay, so that's what I'm talking about when I'm talking about fluid balance. If we have any illness or injury that causes fluid to be in the wrong place at the wrong time, containing the wrong solutes, that's when the body goes into shock. So what I'm talking about is physiological shock. So shock is something that affects all parts of the body. We can develop shock in a split second. Sorry, I'm just going to pause to address this question. The right amount of fluid intake for a child. I don't have a number, so I can't answer that question. You might want to focus that on one of your child lecturers. Obviously, it's going to be dependent on size and weight and exertion, but it would be considerably less than an adult of 1500. So a 7 to 9 year old child wouldn't need as much fluid as an adult. What do I mean about what do I mean by solutes? Then yes, I am talking about electrolytes, but I'm talking about more than just electrolytes. Electrolytes would be our sodium and our potassium, our calcium, our magnesium. Our solutes are everything. So our levels of glucose in the blood, our levels of oxygenated red blood cells in the blood are not just our sodium or our potassium, which is what we're referring to when we talk about electrolytes. Okay, so that answer those questions? So electrolytes refers to something quite specific, and solutes is much more of a generalized term. So going back to shock, so it affects all parts of the body. It can develop very slowly over a period of days or weeks. It can equally happen very rapidly. It can happen over a split second. And when I'm talking about shock, I'm talking about the loss of circulating volume. So the loss of that fluid that I've been talking about up till now, which causes poor tissue perfusion. And what I mean by that is that there is a drop in volume, or there is a lack of the right fluid in the right place. So we might have a lot of circulating volume, but it isn't in the right place, or a lot of it has gone to a specific place and isn't circulating around the body. That causes poor tissue perfusion, and poor tissue perfusion leads eventually to death of tissue and then death overall. So this is a loss of circulating volume. So we talk about the stages of shock. If you don't mind, I'm going to come back to that question about diabetes in a moment. We talk about the stages of shock. We talk about the first stage is compensatory shock. And hopefully all of you have heard about the fight and flight response. This is where the body adapts to what's going on externally or internally, and it can still regulate all tissue perfusion. So if you are able to maintain all of your body systems, then you're in compensatory shock. So the body is working extra hard to ensure that everything's still working correctly. As soon as it tips out of balance and the body can no longer manage the situation, we start talking about progressive shock. And progressive shock is where the body is going to start to show signs that things are going wrong. And those changes can be very subtle and very small. And what's going to be very important when you're managing patients is that you can tell and detect those signs of early progressive shock. Because if we can detect those early signs, we can prevent the patient deteriorating. So while the body is in fight and flight mode, we might not detect anything is wrong. But when the patient moves into progressive shock, that's when either the pulse, the blood pressure, the temperature, the pallor, all sorts of subtle things might change to indicate to us that there's a problem. If we don't do something at this stage, if we don't manage progressive shock, then the body goes into irreversible shock. And once we're in that stage, it means that we are heading towards a catastrophic failure of organs, and then the patient's going to die. And if a patient has reached irreversible shock, there is nothing, we can't prevent certain amounts of cell death. We might be able to prevent the patient overall dying, but we won't be able to prevent some sort of cell death. So we need to detect the subtle changes in progressive shock so that we can prevent the patient deteriorating further. Somebody's asked a question about, do diabetics need a higher or more adequate intake of fluids? Their fluid intake does not get changed because of the disease. It's the type of fluid. So a diabetic would need to be in good fluid balance, but we would have to be aware and knowledgeable of what type of fluids that they were taking in. So being diabetic doesn't make any difference to the amount of fluid that you need to take. You need to have as an input but as a diabetic, it is important that you maintain your fluid balance. So as a diabetic, it would be important that you would have to be well hydrated, for example, or and have a good diet. Okay, we're going to cover that in a minute about preventing the patient going from progressive to irreversible. And it's not just about water. So it's going to be about fluid intake. It's going to be, we're going to have to think very carefully about why they're in progressive shock in the first place, and that's how we'll manage the patient. So we've gone from compensatory, progressive and irreversible shock. So those are the stages of shock. Now we need to spend a little bit of time talking about what types of shock there are. And we're going to talk about 3 different types of shock today. We're going to look at the classification of hypovolemic shock, cardiogenic shock, and distributive or vasogenic shock. Have any of you heard those terms before? Okay, I'm getting a suite of different answers. Predominantly, most of you have heard of the first one, which is hypovolemic shock. And that doesn't surprise me at all that that's the one that you've all heard of. Some of you will have heard of none of them, but most of you have heard of the first one. And some of you have heard of all three, which is great. It doesn't matter that you don't know what they are yet, because I'm going to tell you now. So the first one that we're going to talk about is hypovolemic shock. So hypovolemic shock. Hypo meaning low, volemic meaning volume. So hypovolemic shock is about the dramatic loss in volume. So that means the volume has gone. And often we are talking about blood volume. Not always, but often. So we're talking about between 15 and 25% of the total volume. So remember, we're in an average 70 kilogram woman aged between 25 and 40. That's going to be 35 litres. So 25% of that is going to result in hypovolemic shock. So often when we're talking about hypovolemic shock, not always, but often, we're talking about a hemorrhage. So we've got blood loss. And that might be from a wound, it might be as a result of surgery or an accident or a puncture wound. It might be the result of vomiting blood, so a hematemesis. So there's all sorts of different reasons why we might lose volume. Sorry, the sound has gone. Is that for everyone or just for Abigail? Okay, I think it must be you then, Abigail, because the sound has gone. The sound hasn't gone for anybody else. So sorry about that. As I said at the beginning, it's being recorded, so you can always listen back to it if the sound doesn't come back. So I'm talking about a dramatic loss of volume, a hemorrhage. So a loss of blood. And because there is a loss of blood volume, there is a reduced amount of blood going back to the heart. So there is a reduced venous return. So if I've, for example, vomited 15% of my blood volume, and that blood is therefore outside my body, there is a reduced amount of blood volume going around my body, which means that there is a reduced amount of volume coming back to my heart. So we talk about the stroke volume, and the stroke volume is the amount of blood that leaves the heart at every beat. So that's reduced. And if the amount of blood that leaves the heart either into the pulmonary circulation or into the body circulation is reduced, then the cardiac output will be reduced. And if the cardiac output is reduced, and that is the amount of blood that leaves the body from the left ventricle, so remember our anatomy, left ventricle out via the aorta, that is our cardiac output. So our stroke volume is what leaves the heart to go around the body and what leaves the heart to go around the pulmonary circulation, and the stroke volume is what's leaving the heart to go around the body. And if we've got less coming into the heart, less going round the heart and less exiting the heart, then we've got decreased tissue perfusion. So the volume has gone down across the board. So how are we going to, how are we going to manage that? What do you think is going to be our best course of action if we've got a loss in volume? Excellent answers, really excellent answers. You're all absolutely right. Yes. One, we've got to stop the bleeding. So if it's if we're vomiting blood, then do something to stop the vomiting blood. If we are bleeding out from a wound, then we've got to stop the bleeding first. But yes, absolutely. The first course of action is going to be to stop the bleeding, and the other first course of action, so equal first, is going to be replace the fluids. And that might be with a blood transfusion if we're lucky enough to have cross-matched or O negative blood available instantly. But if we don't have blood available instantly, then we will want to replace the fluid with whatever we have. That might be an IV crystalloid, so something like normal saline, which isn't great in this setting, but if that's all we've got, then it's better than nothing, because we're better off with something like a colloid, so a Hemocell or something that's going to have some volume to it. Crystalloids are a bit thin and weak. So we've got to get IV fluids started, and we've got to replace the blood volume with blood, ideally, but if we don't have blood, with something else. So we've got to bump up the blood volume. And that's going to be our first course of action: stop the bleeding and IV fluids. So that's absolutely correct. Well done. What's going to happen to the patient's observations, do we think? So what's going to happen to the patient's pulse? Okay, some of you are, so the pulse, well, I'm getting a mixed answers now. Okay, because we've got a reduction in the amount of blood volume leaving the heart will think, I need to work harder to get the little volume I have around the body. So what the heart will do is the heart will speed up. So those of you who said the pulse will increase, you were right. I understand why some of you might have thought that the pulse would go down, but it won't. In the progressive stages, and we're in the progressive stage of shock here, the pulse will start to go up. The pulse will go up because the heart is trying very hard to send as much as it possibly can around the body. It's going to start thinking, okay, I've only got a little bit, so I need to pump faster and faster and faster. So the pulse will go up. Some of you mentioned the blood pressure there as well. And the blood pressure will go down, because the blood pressure is a measure of stroke volume and cardiac output, as well as the ability of the heart to beat. So the blood pressure will go down. So we might see the blood pressure going down quite dramatically if the patient is in progressive shock. But initially, and this is where it's so important to detect the early signs, the pulse is going to be the first thing to give away that the body is starting to adapt to what's going on. And the pulse will start to speed up. That will be the first thing that will happen. And then the blood pressure will go down. So we'll have a raise in pulse and a drop in blood pressure. So we've got a diastolic blood pressure, which is the bottom measurement, and we've got the systolic blood pressure, which is the top measurement. And in hypovolemic shock, both the systolic and the diastolic will drop in pretty much equal ranges. So the gap between our diastolic and our systolic blood pressure will be approximately the same. They will both go down in hypovolemic shock. Any questions on that? No? Okay, so that's hypovolemic shock. So another, a few physical assessments that we might do is, as the patient is losing volume, they might become cold, their peripheries might become cold and clammy. So we will need to keep an eye on their temperature as well as their pulse and their blood pressure. And we will need to keep a close eye on their fluid balance. So ensure that we've got a very clear idea of what we're losing in terms of the bleeding, and that might be an approximation, but a very clear idea of what we're putting in. So that's when recording what we're putting in on our fluid balance chart is going to be very, very important. When we're monitoring the blood pressure, it's always a comparative thing, isn't it? So we talk about a normal blood pressure being 120/80, but how many patients do we look after have a blood pressure of 120/80? Very few. So I'm talking about a dramatic drop in blood pressure. So I'm talking about approximately 40 millimoles of mercury per measurement. So 40 millimoles of mercury would be, with a blood pressure of 120/80, a blood pressure going down to 80/40. And that would be considered a very low blood pressure and a very dangerous. But if your blood pressure is normally 90/60, then 80/40 might not be that bad for you. So it's always comparative. So we're looking at between a 30 and 40 millimoles of mercury drop would be considered the patient in hypovolemic shock. Does that answer your question, Audrey? Okay, great. So that's hypovolemic shock. So we've got that dramatic loss in volume, and loss is the important word here in hypovolemic shock. Now I'm going to talk about cardiogenic shock. So many of you hadn't heard of this one. Most of you had heard of the first one. So cardiogenic shock is about the heart. We're talking about the heart's ability to pump. So the volume hasn't gone anywhere, hasn't been lost. It's just not in the right place. Because when we're talking about cardiogenic shock, we're talking about the heart itself. And we can either be talking about coronary cardiogenic shock or non-coronary cardiogenic shock. Coronary cardiogenic shock means within the heart itself, and non-coronary cardiogenic shock refers to factors external to the heart but affecting the heart itself. So the volume itself hasn't been lost. So we're not talking about a hemorrhage where the blood has left the body. We're talking about the volume not circulating around the body correctly. This causes cardiogenic shock, causes decreased cardiac contractility. That means that the heart's ability to pump is not as good as it was. So if we think of the heart as a muscular pump, for some reason that muscular pump is not working as effectively as it was. This leads to a decreased stroke volume, so that's a decreased amount of blood that's going around the whole circulation in the heart, and a decreased cardiac output. That means that the amount of blood that is leaving the heart from the left ventricle is decreased, so what's leaving the aorta is decreased, which means that there is a decreased systemic tissue perfusion. So the tissues around the body are becoming less well perfused. So the end point of cardiogenic shock is similar to the end point of hypovolemic shock, but this isn't because the volume has gone down, it is because the volume isn't circulating appropriately. What might be, do you think, an example of coronary cardiogenic shock? Can anybody think of something that might cause the heart itself not to beat very well? Lots of excellent answers. Absolutely excellent. Really pleased with those. So we've talked about, people have mentioned AF, atrial fibrillation, myocardial infarction, or a heart attack. But we're all nurses now, so we're going to say myocardial infarction, not heart attack. So these are, you've given me great examples of the heart itself being in trouble. So either because of some muscle death caused by a blockage, which would be a myocardial infarction, or an electrical problem where the electrical signals that go down through the heart and tell the heart to beat in a coordinated fashion, like AF. So we've got two different examples, two really, really good examples of when the heart doesn't work appropriately. I'm going to come to what. So those are really excellent examples. So can anybody think of an example of a non-coronary cardiogenic? Oh, some really interesting answers. Stroke, no, nothing to do with, we're not talking about anything to do with the brain or the brain or anything to do with the TIA or so on. So this is, although that might have a knock-on effect and cause coronary cardiogenic shock, because in a patient who's had a stroke, that might cause the centres in the brain not to send the right message to beat. So that might be a reason for coronary cardiogenic shock. But non-coronary cardiogenic shock, some people are coming up with some great examples, and those great examples are things like pulmonary embolus or respiratory problems. Because let's think about the geography of the heart and where it is. The heart is in the centre of that thoracic cavity, and it is in a bag, isn't it? The heart is situated in a myocardial sac and pericardial sac. And if anything happens around the heart that causes something to press on the heart, so a pulmonary embolus or a pulmonary effusion or a respiratory distress where the lungs are pressing on the heart, or some actual physical damage around the heart, that's going to cause the heart its ability to pump to be impaired from an external factor. Some people have given examples of a DVT. A deep vein thrombosis is where we've got a clot somewhere in the venous system, often in the peripheries. So it might impair the amount of venous return, but it isn't going to necessarily cause non-coronary cardiogenic shock. A respiratory arrest might be an example of when the lungs have failed catastrophically, but again, that wouldn't necessarily cause non-coronary cardiogenic shock. So any other example? So fluid buildup around the heart. Fluid that could be caused by something called a cardiac tamponade, which is where the sac the heart actually sits in is filling up with fluid or blood, maybe caused by an injury. Often a cardiac tamponade can be caused by a rib injury. So yes, cardiogenic shock is mainly related to issues with the heart itself, if it's coronary cardiogenic shock, or things around the heart itself or around the heart, for example, the lungs. So it's about what's happening in the actual thoracic cavity if we're talking about cardiogenic shock. So some excellent answers from everybody. Asthma is a respiratory disease. It may cause a different type of shock, but it's not going to cause coronary or cardiogenic shock. So we've got the heart's ability to pump being impaired. This means that as I've said, the stroke volume and the cardiac output are incorrect or are decreased. So what's going to be our immediate course of action? Okay, I'm getting some very, very interesting answers. Okay, so the heart's ability to pump is impaired. So we've got to do something about that first. We've got to repair the damage if damage has occurred, or we've got to improve the electrical conductivity in the heart in the case of AF. So we've got to resolve the internal heart problem itself. Some people have mentioned CPR. Well, hopefully that we won't need that, because we're not going to start cardiopulmonary resuscitation until when the patient hasn't arrested. Some people have mentioned an ECG, and ECG is going to be very important to help us diagnose. And if we've got the patient on a continuous heart trace, we may be able to identify what the problem is in terms of the internal problems in the heart. So we might have to, we might know what doses of a cardiac drug to give if we've got an ECG to give us as a diagnostic tool. So the patient is presenting and they've got coronary cardiogenic shock. Some of you have mentioned IV fluids. You have to be very, very careful with IV fluids or any fluids of any type with cardiogenic, coronary or non-coronary cardiogenic shock. And the reason you've got to be careful is that the volume is still there. We've had no loss of volume in terms of it exiting the body. It's all still in the system somewhere. So if we put more in, if we put more fluid into the system, we're actually going to cause more problems than we're solving. So we might actually cause the heart to fail even more if we put more pressure on it. So IV fluids can potentially be very dangerous. We might start a very slow infusion, and patients who have myocardial infarctions are started on IV infusions, but only very slowly and very carefully monitored. Because we don't want to put lots of fluids and therefore put extra pressure on the heart, which is already struggling to beat. What do we think is going to happen to the blood pressure and the pulse? Okay, getting some very, very mixed answers. So the heart's ability to pump is impaired. So what's going to happen initially, and again, if you remember, I talked about how it's going to be very important to detect subtle changes. the pulse initially will go up, and it will go up quite dramatically. So the patient may become very tachycardic. Far more tachycardic, far quicker than a patient in hypovolemic shock, because this is the heart itself that's in panic mode. It can't do what it's meant to be doing. It can't do it properly. So it does panic. And what you will find is not only will the pulse go up, but it will become irregular, and you will not have the same rest and recovery periods that you had in a normal heartbeat. So there won't be the ba-boom that we're used to. There will be a variation in all of those different pulses and noises, which we will be able to see if we've got the patient monitored on a cardiac monitor. But their pulse will go up, it will go up quite dramatically, it will go up quite quickly, and that change may be quite dramatic. The blood pressure may not be quite so dramatic, whereas in hypovolemic shock, with the loss of volume, there will be a dramatic drop in diastolic and systolic blood pressure very quickly. In cardiogenic, both coronary and non-coronary cardiogenic shock, there will be a drop in blood pressure, but that drop in blood pressure may be quite subtle, and it might be quite slow in its presentation. So the patient will not drop their diastolic and their systolic blood pressure very quickly. They will drop, but not as quickly as they did in hypovolemic shock. So there's a clear diagnostic difference between those two types of shock. And if we've been monitoring the patient closely and we've been recording the observations on a regular basis, maybe every 15 minutes, then the differences will be quite obvious. The patient's pulse will go up, as I said, quite dramatically, quite quickly, and it could become very quick. So we could have a patient having a tachycardia, 120, 130, even higher sometimes. The patient will stay in a tachycardic phase, tachycardic presentation, until the heart itself fails. And if the heart itself fails, then we are going to be in a CPR situation. So if the pulse does, as mentioned in one of these questions, fail eventually, then it will, if the heart fails catastrophically, then the pulse will then drop, and that's when the patient will arrest. I'm just going to press pause for a moment on the presentation because I've got some technical problems this end. So just one moment, and I'm just going to pause. Apologies, that was nothing to do with you, it was my end. I had just a slight technical problem with the computer. Okay, so coronary and non-coronary cardiogenic shock. We've had this dramatic raise in pulse, we've had a slow, subtle drop in blood pressure, and if we've been recording the observations, it will be quite a different presentation to the patient who's in hypovolemic shock. They will possibly become quite cold and clammy because, again, we've got poor tissue perfusion in the peripheries. So they might present as being cold and clammy, and they might equally be in quite a lot of pain, quite a lot of discomfort. So associated with a myocardial infarction or associated with a non-coronary cardiogenic shock, such as a cardiac tamponade, the patient will have a presentation of pain. And there won't necessarily be a presentation of pain in hypovolemic shock. So these are all subtle differences in their presentation. So coronary and non-coronary cardiogenic shock. Are we happy with those? Has anybody got any questions? The pain may be localized to the sternum, but it also might be specifically in pain associated with myocardial infarctions. It might be all across the chest, across the back, maybe down the arms. We talk about central crushing chest pain radiating down the left arm, which is a textbook presentation of a patient with a myocardial infarction. So yes, the pain may be localized to the sternum, and if we've got non-coronary cardiogenic shock caused by cardiac tamponade, which is caused by a broken rib, then that might be very localized pain. If we've got a coronary cardiogenic shock caused by a myocardial infarction, that might be quite generalized thoracic pain. But cardiogenic shock does often, not always, but often present with some pain associated with it. Which is often why we give a diamorphine or a morphine sulfate substitute when patients have myocardial infarctions. So if the patient's presented with a myocardial infarction, for example, we'll give very slow IV fluids because we don't want to put extra strain on the heart. We'll give analgesia, we'll give oxygen to ensure that the blood that is circulating is well oxygenated, and we will monitor closely. Any other questions? So we've talked about hypervolemic shock, we've talked about cardiogenic shock. Now we're going to talk about the next one, which is distributive shock. And this is often the one that few of you have heard of. When we're talking about distributive shock, we're talking about septic shock, neurogenic shock, and anaphylactic shock. So have you heard of those types of shock? Fabulous. So a lot of you, if not all of you, have heard of septic shock or sepsis. A lot of you, if not all of you, have heard of anaphylactic shock. You may not have heard of neurogenic shock. So what are we talking about when we're talking about this type of distributive shock? We've talked about one where we've lost the volume. We've talked about one where the volume isn't being pumped around the body properly. This type of shock is where the volume has gone to the wrong place for whatever reason. It's not in the right place. So if we go back to that much earlier slide when I talked about the right volume in the right place with the right solutions. In distributive shock, the fluid, the body fluid isn't in the right place. So it's not distributed appropriately. So it hasn't gone anywhere. It hasn't left the body. It hasn't, it's not the heart's ability to pump that's the problem. It is there. It's in the volume that's in the body. It's just in the wrong place. So it might not be in the blood. It might be in the tissues. So how does a patient in distributive shock present? What happens to them? So let's use anaphylactic shock as an example. What happens has anybody got an allergy to anything? What happens when you are exposed to that thing, if it's a nut or whatever? Yeah, I'm getting a Okay, well, somebody's describing their actual anaphylaxis. I'm hoping you're not having it now. But it's inflammation is absolutely the right answer, swelling and inflammation. What happens is the fluid goes to the wrong place. So those of you who've mentioned swellings of face and tongue, that might be, for example, if you've got a nut allergy and you put a nut in your mouth, your face, your tongue, your mouth, your airway swells up. The volume in your body hasn't gone anywhere. It's gone to the place where you've been exposed to whatever you're allergic to. We've talked about rashes and redness and hot and all of those. So not only is the fluid, but the heat and the rash is about the blood volume going to a specific place, which is why we become red and it becomes raised. It can get a very high colour, so you can look very, very flushed. So this is all about the volume is rushing to the place where we've exposed it to the allergen. So if, for example, we've got, as I said, a nut allergy, it's going to happen in the mouth and the face. If you're allergic to a particular soap and you rub that soap on your skin swells, becomes red, becomes itchy because there's an increased amount of histamine, which is a chemical in the blood, going to that particular area and causing swelling. So every single cell is therefore filling up. Every single cell is becoming bigger. So it's not just what's happening in the blood volume. Every single cell is becoming bigger and more swollen. So we've got a whole system around the body that's becoming swollen up. And what happens is we get vasodilation. So all our vessels in that area, so if we've rubbed, as somebody's given the example of an elastoplast, plaster on your skin, all the veins and all the vessels around that particular area that's been exposed will open up, will dilate. There will be a volume rushing to that particular place, whatever the place that's been exposed is. So we've got a vasodilation. We've got all the channels to that area that's affected are opening up. That causes a drop in venous return, because if all the fluid is rushing to one place, it can't be being pushed back up to the heart. Therefore, again, we've got the same thing as happened in the others. We've got a decreased stroke volume and we've got a decreased cardiac output, and we've got therefore a knock-on effect of a decreased tissue perfusion. So the effect of this rush of fluid is the same as the other two, but it's for a different reason, completely different reason. So in anaphylaxis, that is localized to whatever area has been exposed to the allergen. In septic shock, it might be a localized infection, so the fluid is rushing to that infected area. So if we've got a cut on our hand and that cut has become infected, the fluid is going to be rushing to that cut on your hand. So your arm and your hand itself may swell. But if the infection is systemic, is all over the body and is in the blood, we've got a general vasodilation. So everywhere in the body is dilating, which is why sepsis is so dangerous, because we're not applying the problem to one local area like we are with we've got a cut and infected hand. We're talking about our whole body being infected. So every cell is expanding and filling with fluid. So the circulating volume becomes less because it's going to the cellular level. In neurogenic shock is associated with spinal injury. Then we've got it going to a particular area of the central nervous system. So if we've got a spinal cord injury in the thoracic spine, then that fluid is going to be heading to that area of the thoracic cavity. So what do we think is going to happen to the blood pressure and the pulse? Firstly, the pulse. What's going to happen to the pulse? Okay, I'm coming up with some great answers. Particularly Georgina, well done. Yes, you're absolutely right. Yes, it will. First of all, it will go up initially. It will go up quite quickly initially, in the same way as cardiogenic shock did, go up quite quickly, but then it will drop off. So remember I told you at the beginning to think about the very subtle changes in presentation. So we're going to have a pulse that's going to go up initially because the body's going to go into panic. It's going to go into panic mode as it's going into progressive shock, but as it's got into progressive shock, then the pulse may go down. So a patient who is septic may become quite bradycardic. Their pulse might drop off. So whereas we've got in hypovolemic shock the pulse going up slowly and staying up, and in cardiogenic shock we've got it going up very quickly and staying up very high. In septic shock or distributive shock we've got it going up very quickly and then we've got it dropping off. So some subtle differences in our patient's pulse rate. And it is also going to weaken because the amount of circulating volume, the amount that we've got to exit the heart is going to be dropping. And if the patient is septic, that's going to be dropping quite quickly. And then it's going to become quite weak. So the pulse will go up, yes, but it will then go down and it will become quite weak. What's going to happen to the blood pressure? Okay, so some of you are coming up with great answers. The blood pressure will go down. It may not go down that dramatically, but it will go down because we've got a drop in circulating volume. And which measurement, the diastolic or the systolic, tells us about circulating volume? Either everybody's gone to sleep or they can't type or they don't know the answer. So which one is it? Is it the top measurement or the bottom measurement that talks about the amount of circulating volume? Is it diastolic or systolic? Can we remember? You're absolutely right, those of you who've said the top measurement, but the top measurement's called what? The systolic measurement, right? The systolic, wait. Some people can't spell systolic, but don't worry. Okay, the systolic measurement is the amount of cardiac output. So the systolic measurement is going to go down. The diastolic measurement, for those of you who said diastolic, the diastolic measurement is about peripheral resistance. So what's happening in the peripheries? What's happening out in the body if we're in vasogenic or distributive shock? If we're in distributive shock, we've got vasodilation. If we've got vasodilation, then we've got a reduction in the peripheral resistance. So there isn't a lot going on. Well, there is a lot going on. There isn't a lot of resistance out there in the body because we've got this dilation because of what's happening. So the systolic blood pressure will drop a little bit, but the diastolic blood pressure will drop even more. So do you remember I talked about the gap in hypovolemic shock and the gap pretty much staying the same? So if we were going from 120 over 80, we'd go to 100 over 60, we'd go to 80 over 40. So the gap between the diastolic and the systolic would pretty much stay the same in hypovolemic shock. In septic shock, or vasogenic shock, or anaphylactic shock, the blood pressure will go down, but the gap between the systolic and the diastolic will get bigger, because the peripheral resistance out there in the body is becoming much less because of this systemic vasodilation. And so the diastolic blood pressure will go down more than the systolic blood pressure. Does that make sense? So remember, I talked at the beginning about these subtle changes in observations and these things that we've got to think about very carefully when we're doing the observations of our patients and how they are changing and what's going on, that this is going to be a really clear sign that our patient might be going into distributive shock. If their blood pressure is going down and the gap between the two measurements is becoming subtly bigger. So we've got the pulse going up and then maybe going down, and we've got the blood pressure going down, but the gap becoming bigger. What are we going to do? What's going to be our action? What's going to be our instant management? Yes, one of the things that we've got to do very quickly is to treat the reason for this shift in fluid. Because by putting more fluid in, we're not actually going to solve the problem, because it's just going to carry on going there. Yes, we're probably going to start some fluids, but we're going to treat the infection or treat the allergic reaction. Or in the case of a spinal cord injury, treat the spinal cord injury, which might mean alleviating the pressure. So in terms of an allergic reaction in an anaphylaxis, we're going to give adrenaline, we're going to give antihistamine. In the terms of sepsis, we're going to treat the infection, which might involve giving IV antibiotics or antibiotics of some description, or antivirals, depending on what's causing the sepsis. Somebody's mentioned sepsis 6. Sepsis 6 is a recommended pathway of care that is implemented when a patient has been diagnosed as septic, and it talks about treating the infection, giving some IV fluids to manage any kind of loss of volume, giving oxygen to ensure that the patient is well oxygenated, and I've lost my train of thought, sorry. So giving IV fluids, giving antibiotics if those are necessary, so treating the cause of the infection, and they recommend a first course of action in sepsis 6, oxygen, fluids, and maintaining the patient's fluid balance and maintaining the patient's temperature. Because if a patient has become septic, They may become hyperthermic, they may get a high temperature, but equally they might become hypothermic, they might get a low temperature, because not everybody that's got an infection gets hot. Some people get very cold because of that shift in volume. And if the patient is old and they've got less volume to talk about, because we talked right back at the beginning, didn't we, about how a patient will lose volume as they get older. So if we've got an elderly patient who's septic, we've got to put in a bit more fluid, but we've equally got to maintain an appropriate fluid balance, which is going to be very, very important. So our management is going to be fluids, but treating the cause of the shifting fluid first and foremost. Okay, so we've got distributive shock, septic, neurogenic, and anaphylaxis, and this is where the volume hasn't gone anywhere, and it's not the problem with the heart pumping it around the body, but it's gone to the wrong place. So it's in the wrong place, and it can't be useful when it's in the wrong place. Any questions on distributive shock? Raising the legs above the heart. Why would you think that that's a good idea? Explain your thinking. I'm not sure. Okay. Although that's not a bad idea, I'd always be very careful about raising the legs to improve the venous return, because I'd have to think very carefully about whether my patient would be able to cope with it. So it would have to be on a very individualised basis. I'd have to think about whether it's a good idea, because what we don't want to do in a patient, for example, if we had an elderly lady who was septic, the chances are that that's not the only thing that's wrong with them. So if they had any kind of cardiac condition, high blood pressure, any kind of circulatory problems, cardiovascular problems, I wouldn't want to put sudden and extra pressure on the heart. That might be catastrophic. If the patient was young and fit and healthy and had just been stabbed, then yes, I might consider raising the legs to improve the circulating volume and to put to improve the amount of cardiac venous return through lifting up the legs. So I might do it, but it would have to be thought through on an individual basis. Yes, you're absolutely right, Caroline, that some people do have compression when they've got cardiac problems. And it might be, that might be to improve circulating volume, it might be to improve adequate venous return, but it's closely monitored, and we have knowledge that the patient has no pumping issues with their heart. So if they are in if they have a particular condition which means that their venous return is slow for all sorts of reasons, then we might use compression, but it would have to be something that was well thought through. How would I decide? I would want to know about the strength of their heart and their heart's ability to pump. So I might have done an ECG, or I might have done an echo, where I've got a clear indication that the heart is functioning correctly. Does that answer your questions? Any other questions? So just briefly to recap, we've got hypovolemic shock. So that's where we've got a loss in volume. We've got cardiogenic shock, where it's about the heart's ability to pump, and that might be for internal or external reasons. So we talk about coronary or non-coronary cardiogenic shock. And then we've got distributive shock, where we haven't lost the volume, it's just that the volume's in the wrong place, and we've got to move it back into the right place. Okay, so we've got 3 classifications of shock. At the beginning of the session, did you think that you had looked after a patient in shock? And have you now changed your mind? Are you sure you haven't experienced a patient in shock? You haven't looked after anybody that's got an infection or got a cardiac problem or maybe had surgery? Shingles can be a very dangerous disease actually, because it can cause distributive shock. It's an aggressive viral disease that can cause a patient to have a real shift in volume, and especially in the elderly, it can be potentially very dangerous. So I would suggest that yes, they could develop distributive shock with shingles, and it can be quite dangerous. I would challenge you to think that maybe every single one of you who's cared for a patient has probably looked at them and done their observations and done their fluid balance, and what you're actually looking for is signs of progressive and progressive shock, that you're hoping that the patient is maintaining their all their body systems and staying in compensatory shock. And you're going to prevent them going into progressive shock. And if you're going to the clinic, is that CDU, is that the clinical decision making unit, you're going to come across people with potentially catastrophic things going on in their body, and you're going to have to think very carefully about their observations and what assessments that you're doing. So I probably should start the session by saying, has anybody looked after a patient in shock, and then see if you change your mind after the session, because a lot of people are, when I say shock, they're just thinking of people that are bleeding to death. Well, that's going to be a tiny, tiny, tiny proportion of the people that you look after. Those of you who go and work in accident emergency, when you qualify, might come across people in hypovolemic shock very often. But most of us who are managing patients all over the hospitals, and when I was in practice, I worked in intensive care, practically every patient I was looking after had some form of shock, whether it be hypovolemic, cardiogenic or distributive shock. So it's something that you manage on a daily basis, but you don't necessarily know that you are. So I think I've covered this in a detail already as we've been going along, but one thing I did want to highlight is the absolute essential aspects of patient assessment. Throughout your care and management of a patient who's in progressive shock, it's going to be, as we've already stated, those subtle changes in observations that are going to give you the indication that the patient might be tipping over the edge out of compensatory shock and into progressive shock. And we've got to do something very, very quickly when the patient goes into progressive shock to prevent them going into irreversible shock. Because if they go into irreversible shock, then we've got serious and unresolvable problems, which may lead to death, which is obviously a very serious and unresolvable problem. So those subtle measurements in pulses and blood pressures, those subtle changes in the difference between the two measurements. So not just looking at a blood pressure going down, but looking at how the blood pressure is going down. Is the diastolic and the systolic getting bigger, the gap between the two, or is it getting smaller? Is there something going on that would mean that there's less peripheral resistance, more peripheral resistance, less circulating volume, more circulating volume? So what's changing in the physiology that makes us think that the patient's going into progressive shock? What's happening with the pulse? It might be going up, but is it going up and dropping off a little bit? Is it going up and carrying on going up? Is it going up and becoming less regular, becoming more thready, becoming less even than it was when we started our observations? So it's these subtle changes that only you as the practitioner actually undertaking those observations will be able to detect. And they don't necessarily transfer very well to that physical sheet if you're writing the observations or if you're entering them into a computer. Those subtle changes don't transfer into the written form. You're going to have to be the one that detects those subtle changes. To answer your question, Audrey, sometimes in cardiogenic shock, coronary cardiogenic shock, because we're talking about the heart, peripheral resistance can remain unchanged. So the diastolic measurement will remain unchanged, but it is the systolic that is changing. So I don't think I mentioned that, did I? So in coronary cardiogenic shock, we can sometimes have a closing of the gap between the diastolic and the systolic measurement, whereas in distributive shock, we have a widening of the gap. Does that make sense? Yes and a no. Okay, going back a bit. If it's the systolic measurement and the diastolic measurement, if we go back to those, the systolic is about the heart itself and the diastolic is about peripheral resistance. So have I gone around the wrong way around? Yes, no, that's right. So in distributive shock, the diastolic will go down more than the systolic. And in cardiogenic shock, sometimes, not always, and this is why I didn't mention it initially, sometimes the systolic can drop more than the diastolic does because the peripheral resistance, what's going on around the body, is remaining relatively unchanged. Okay? So it's those subtle changes that you're going to notice as the person undertaking these observations. So it won't be enough in a patient with in shock to say to your mentor their blood pressure's gone down. You're going to need to give them a bit more information, and as you get more senior, so when you go into the second year and then finally in your final placements in the third year, when you're being asked to relay your patient's condition to either a senior member of nursing staff or even the doctor, it's going to be those subtle changes that you will be able to detect, which will give you a real clear indication that there's something going wrong with the patient. So be able to say to the doctor or the senior nurse that their diastolic and their systolic is changing, their pulse tempo is changing. Those subtle changes are going to make a big difference to your assessment. And this assessment tool, I'm sure you've all come across with the ABCDE. It's very important to think with a patient in shock that you're going to be using this assessment tool. So obviously we're looking at the airway and the breathing because they're always going to be one of our primary concern. But it's that C, it's that circulation in types of shock that we're going to focus some of our attention on, and we're going to make sure that we understand why the circulating volume is behaving in the way that it is. Because if we go back to right at the beginning of the presentation, I didn't talk about fluid just for the sake of it. It was about understanding why that circulating volume is so important and understanding where it is and why it's in the wrong place or where it's gone. So that's circulation, what's happening to the patient's blood pressure and pulse. Their disability and their exposure are equally going to be as important, to try and identify what type of shock they're in, what stage of shock they're in, and therefore what our management has to be. So obviously we're going to be doing their respiratory rate, but their pulse and their blood pressure is going to be vitally important. And we are going to take their temperature. And as I mentioned, the patient may become cold, their periphery might become cold, but their temperature may not change, their core temperature may not change. But if they've got a loss in volume, like in hypovolemic shock, they may become quite cold because the volume that you're putting in blood products or in crystalloids might not be as warm as their body. So you might drop their circulating volume temperature and that might cause problems. So keep an eye on the patient's temperature. Any questions? No? Okay, nothing's being typed at the moment. So I just wanted to thank you very much. I'm glad you've enjoyed it. Just wanted to make the point that yes, I've sent the presentation and a supplementary piece of work that I did a while ago, which is taken from a couple of the textbooks, which gives you a little bit of background information into shock and the significance of shock. And I've sent those two documents to Caroline, so I'm sure she'll upload them to the DLE. As I said, I'm recording this presentation, so I will send this recording to Caroline, and she will upload it to the DLE as well once it's converted, so all the information will be there. Audrey, you've asked a question, what happens if fluid is inputted too quickly? What might happen? Well, a number of things might happen. If we've got a patient who's in hypovolemic shock and we put in fluid too quickly, what we can do, if that IV fluid isn't the right IV fluid, so if it's a crystalloid, we might dilute what's going around the body, and that might cause problems. The patient might become quite unstable, but if we're putting in blood, we should be fine as long as we're monitoring it. But we've got to make sure, if we've got a patient in hypovolemic shock, we've got to make sure that what's going in is being managed and they've still got a urine output, because if they've had a massive loss in fluid, the kidneys get quite sensitive. And you mentioned, all of you mentioned pretty much at the beginning, that the kidneys is your regulator, is what's important in regulating fluid. So if we've had a massive loss in volume and the kidneys have been affected, they may fail. So we'll have to make sure that we're maintaining a fluid balance and a urine output. So that's in hypovolemic shock. If we put fluids in too quickly with a patient in cardiogenic shock, we're going to make them worse. So a patient in cardiogenic shock, we're going to put too much pressure on the heart. We could actually cause the heart to fail and cause an MI. So if we're putting a lot of fluids in very quickly to a patient in cardiogenic shock, we might send them into irreversible shock. If we put fluids too quickly into a patient in distributive shock, we might have problems with fluid balance. So we might have a problem with the kidneys, we might have a problem with the heart. So again, it's about monitoring and carefully putting them in, depending on what type of shock it is. But the most dangerous type of shock to put fluids in quickly in is cardiogenic shock, because if we put more pressure on the heart will fail. Does that answer your question? Okay. Okay, any other questions? Well, thank you very much for your attention and your input. It's been great. I hope you've enjoyed it. And as I said, it'll all be uploaded to the DLE, so you'll have access to it in the future. And if you've got any questions, then don't hesitate to contact me or contact Caroline, your module lead. But thank you very much for listening, and I will catch up with you probably in the third year, because I don't teach on the second year. Okay? Thanks very much.